So good afternoon, everyone, and thank you for joining us. My name is Steph Kershaw. I am a postdoctoral research fellow at the National Drug and Alcohol Research Centre at the University of New South Wales. I'm also the project coordinator for Cracks in the Ice, and I'll be chairing our webinar session today. I'd like to start by welcoming you to the webinar. It's wonderful to have you all with us. And today's presentation is one in a series of webinars which will be focused on crystal methamphetamine. And these are running as part of the Australian Government Department of Health funded project Cracks in the Ice. So if you haven't already seen the website, I would encourage you to visit www.cracksintheice.org.au. We welcome any questions or comments that you may have, so feel free to get in touch with us at any time. In a moment, I will introduce today's speaker, but before I do, I would like to let you know that we will be recording today's session and we will be making the recording available as well as the slides for you to download. You will notice that they have a questions tab on your dashboard. This is where you can type in any questions that you have during the webinar and send them to us. We will be having a question and answer session at the end of our webinar, so please do send some questions through for Rebecca. So without further ado, I would like to introduce you to our presenter today, Associate Professor Rebecca McKetin. Rebecca is a Curtin Senior Research Fellow at the National Drug Research Institute. She is also a Visiting Fellow at the National Drug and Alcohol Research Centre. So her research has focused on methamphetamine, for which she received a New South Wales Australian Capital Territory Young Tall Poppy Science Award. So the findings of her research have attracted high-profile media coverage in Australia and internationally. And she's also been cited extensively in Parliament inquiries and the National ICE Task Force. At the moment, her current research includes leading world-first trials into substitution treatments for methamphetamine dependence, as well as the development of novel responses for methamphetamine use in Aboriginal and Torres Strait Islander communities. She is also involved in a longitudinal cohort study and the development of an online intervention for people who use methamphetamine called Breaking the Ice. So Rebecca has also consulted for the United Nations on the development of drug monitoring systems in Asia and Africa. She is the former executive editor of the journal Drug and Alcohol Review, the current assistant editor for the journal Addiction, and a member of the Australian Institute of Policy and Science. So thank you so much for joining us today, Rebecca. We are extremely lucky to have you with us, and I know that it's going to be a really interesting session. So I'm going to hand over to you now to make the presentation.
Thanks, Jeff. Well, that's certainly enough about me, and I'm looking forward to talking to everyone about methamphetamine use today. As Jeff said, we'll have some question time at the end, which I think will be very helpful. But for now, I'll just be doing a didactic lecture, and then we'll do the questions later. So just to give you an overview of what we'll be talking about today, I want to do a bit of a general introduction on why we're looking at methamphetamine use in mental health. Second, I'd like to talk quickly about how common mental health disorders are in this population. And then finally, I'll be focusing on psychosis. Before I start, I'd like to acknowledge that a lot of the data that I'll be presenting today comes from various different studies, and I've got photos here of some of the collaborators on those studies, and just to recognize that this is a multi-institutional effort. So to start with, why methamphetamine and mental health? So there are three key reasons why we see high rates of mental health problems amongst people who use methamphetamine. The first one is the type of people who are using the drug, and this is particularly important when we're looking at people who are dependent on the drug, so not recreational use, but the kind of people we see coming into treatment. A lot of these people have predisposing factors, such as early life trauma and life experiences, that put them at risk of becoming dependent on substances. Once they're in that situation, often they'll self-medicate to cope with depression and other mental health issues that they're experiencing. And this kind of leads to increased substance use. So we get self-medication. That's the second main reason we see high rates of mental health problems amongst people who use methamphetamine. It's actually the other way around, that they have mental health problems, they're using the drug to self-medicate. But in addition to that, the drug use itself can exacerbate problems. So once someone becomes dependent on a drug, even if they are self-medicating, often the dependence on the drug can lead to worse mental health. So it's a bit of a circular problem. Once they're dependent, they end up in a situation where they have financial issues. They might have, you see a breakdown of social relationships, family connections, other environmental changes that can worsen their mental health state. And then you've got the pharmacological effects of the drug itself. And I'm going to talk about that in a little bit more detail in a moment, but this is particularly important for methamphetamine. So essentially what we see is it's not a simple picture. We see a kind of a cycle. We have pre-existing factors, the type of people who are using the drug essentially, such as trauma, genetics, and other life situations. These factors can predispose people to both substance use disorders, including methamphetamine use, and also mental health problems like depression and anxiety. Once people are in this situation, it's kind of like a cycle where the mental health can increase the substance use. The substance use in turn can worsen the mental health problem, and it becomes a bit of a downward spiral. But this is all true of all drugs, but we see a particularly high rate of mental health problems amongst people who use methamphetamine. And there are very good reasons why this is the case when you look at how methamphetamine works. And I'm sure most of you are familiar with the basic pharmacology of methamphetamine. It's a drug that increases the chemical dopamine in the brain, which is very important in reward systems, but it's also very important in making us feel good in our emotional regulations. You can see here the ventral tegmental area, part of the brain, which is filled with dopamine cells. When methamphetamine acts, it increases the release of the dopamine in the frontal cortex and in the nucleus accumbens. And this is the exact circuitry that's involved with regulating emotions. So what happens when someone takes methamphetamine is the dopamine increases, and we also see an increase in the chemical noradrenaline. It's another what we call one of the family of monoamines in the brain. Dopamine makes us feel good. It increases our confidence, our energy and alertness. That's a great thing in short. And also we get this adrenaline, we get this fight or flight response, that real hyped up, we call it sympathetic arousal, like an adrenaline type response. So this is when someone first takes the drug and they feel really good, they feel really hyped up. But what happens when they come down after a binge, after a few days of using the drug, is you get a depletion of these chemicals, dopamine and noradrenaline. If they use very heavily for a long period of time, you also get a depletion of the serotonin, which is quite important in mood regulation and sleep cycles and appetite. And what you end up with is somebody who's quite depressed, anxious, irritable, and has very disturbed sleep patterns. So naturally, people take more of the drug to make them feel good. And one of the interesting things is that acute intoxication effect, it brings back the dopamine and the noradrenaline. So you get someone who feels very confident and energetic and very fight or flighty, so all zing, but it doesn't bring back the serotonin, which is important in regulating mood and stopping the aggression, keeping people a bit zen. So I like to describe people as all energy and fight and no zen when they're using chronically. So that's why methamphetamine is particularly related to mental health problems, probably more so than other drugs like heroin. But what I want to look at now is just how common mental health disorders are in this population. And the disorders I want to focus on first are depression, anxiety, because even though we see a lot of psychosis, we think about psychosis with this drug, we actually see a lot of other mental health problems as well. So this data I'm presenting here, these numbers are related to a cohort of 486 people who are all dependent on methamphetamine, and most of them were entering treatment when we met them. We ran a composite international diagnostic interview over these people, and we diagnosed major depression, social phobia and panic disorder in the past year. And what you can see here are the percentage of these people who had what we call a primary or independent disorder, so irrespective of their substance use. In the second column, what you can see is people who had the same symptoms, so they would have met the criteria for major depression, but they said to us, I only ever get this problem because it's my substance use, and they attributed it to their substance use. And for that reason, rather than say it's a primary disorder, we say it's a substance-related disorder. And then here in this third column, I've said people who had either The really important thing to note here is the high levels of major depression. So 44% of this group of people met the criteria for major depression, and this is in the past year. And that's independent of substance use. In addition, 39% had the same symptoms, but they attributed them to their substance use. Taken together, that means 83% of this sample either had a primary or substance-related major depressive episode in the past year. It's very high. Here we have social phobia and panic disorder. The rates are lower than for depression, but we've got about a quarter of the sample having one or other of these disorders. And again, you've got some people who say, yes, I have the disorder, I have all of these symptoms, but it's only when I use methamphetamine. But all up, taken together, you've got just over a third of these people experiencing social phobia or panic disorder, and these are very disabling anxiety disorders. What's really remarkable though, when you add all of these things together and you go primary or substance related, any one of these disorders, and you're looking at 88% of the sample. So just putting that in a pie graph to see what the world looks like, you can see here that 57% met the criteria for an independent major depressive or anxiety disorder in the past year. A further 31%, I think it is, just around about a third, had a substance-related depressive or anxiety disorder. Only 12% had neither. So essentially what you're seeing is that the vast majority of people who are dependent on this drug present with a major depressive or anxiety disorder in the past year. And some of those people will attribute it to their substance use, and a lot of them won't. To understand a little bit more about how these disorders were related to substance use, we followed these people up a year later. And remember that most of these people were going into treatment, so quite a few of them did reduce their methamphetamine use. So what happened when they reduced their methamphetamine use? Well, let's look at depression or anxiety. 50% all up, remember, had an independent disorder at the start. And if they were still dependent a year later, well, that didn't really change, which is not surprising. However, when we look at those people who were no longer dependent on methamphetamine a year later, some of whom had stopped using the drug altogether, 63% had a depressive or anxiety disorder, so still high. There's not really any overall change. One important thing that you can't see from this is that amongst this group who quit or reduced their use, what we found was that a proportion of them who were substance related here and said, I only get depressed when I use methamphetamine, otherwise I'm okay. Actually, you think when they stop using that the depression will go away. And for some of them it did, but for some of them it didn't. And then they're saying, well, actually, no, I am still depressed now, I've stopped using the drug. And conversely, some people who thought that they had depression before using methamphetamine, when they stopped using the drug, they got better. So overall, you've got 63%, but underneath this, there's a lot of people who may have started with substance-related depression, stopped using the drug, and actually found out that they had an underlying depressive disorder, and vice versa. But the bottom line from this is then that at least half of these people needed intervention for their depression or an anxiety disorder when they went into treatment, because that didn't go away after they stopped using the drug. Suicidality was also very high. We found in the year before treatment, 40% of this sample had thought about committing suicide. 28% had made a plan, and 16% had actually attempted suicide. And we know that the best predictor of suicide attempts is past suicide attempts. So we've got a very high risk population for suicide. So it's something that we need to assess to identify that risk and also have in place procedures to manage that risk. So the third section of my talk, and the longest section of my talk, is about psychosis. When we think about methamphetamine and psychosis, we often think of the images. This is one such image that we see in the media. This is an image from the Sydney Morning Herald of a person who's been taken into the St Vincent's Hospital in Sydney with an alleged methamphetamine psychotic episode. You can see here that they're physically restrained, they're often chemically sedated, they're very difficult for the ambulance officers to manage because they're flailing about and quite agitated. So they get a lot of media attention. Fortunately, these incidents of psychosis, when you look at people who use the drug, are actually not that common. So they're very severe and they get a lot of media attention. But when we do a screening instrument to look at psychotic disorders that would lead to this very severe level of psychosis, what we see is only 13% of the people who use methamphetamine screen for those disorders. And this is amongst people who use the drug at least monthly. Nonetheless, this is still more than 10 times higher than in the general population. So it's still elevated. It's just that most people don't have the really severe psychosis that you see. What we do see is symptoms of psychosis. And I've got here in blue the proportion who had a psychotic disorder and then the proportion who had symptoms of psychosis. And you can see here that 40% had symptoms of psychosis. And this is amongst regular, well, this is actually amongst people who are pretty heavy users, probably dependent on the drug. This is the kind of level that you'd see. It would be a bit lower amongst less frequent users. But essentially, these symptoms of psychosis are much more common. And what causes these symptoms of psychosis is too much dopamine. So like I said before, methamphetamine intoxication increases dopamine. And we know that too much dopamine can cause these psychotic symptoms like paranoia and hallucinations. And we know this because it can be experimentally induced. And then we give an antipsychotic drug that blocks the dopamine and it also blocks the psychosis. And essentially we treat this condition with the same drugs that are used to treat schizophrenia. It's the same underpinning mechanism in both cases. Now in reality, it's a little bit more complicated than that because what we've found is that the symptoms are related to changes in the dopamine regulation, which can occur with chronic use. And this can interact with someone's underlying vulnerability to psychosis. So oftentimes what we see is a very messy picture where someone might have an underlying vulnerability to psychosis. It might be exacerbated by methamphetamine use. In other cases, we see more just acute symptoms that come and go with drug use. And this is what the symptoms are like for the person who's experiencing them. You can see here a quote that we've taken from somebody. And this describes paranoia. Yeah, everyone was out to get me. I always felt like I was being followed. I'll get taxi drivers to drop me off miles away from where I was going. I was afraid people were coming to get me. I swear today there's something behind it. Personally, I think it's real. And hallucinations. This is the other common symptom that you see. I kept seeing people and having conversations with people who weren't there. I sat on the tram tracks having a conversation with someone one day, and a tram was coming. And when my friends realized that I wasn't going to move away, they came and picked me up off the tracks. These symptoms occur on a continuum of severity amongst people who use the drug. So this is again a sample of 310 people who use the drug at least monthly. And amongst those, 1/4 of people in the past year had never had any of these kind of symptoms like paranoia or hallucinations. The majority of people, 52%, they had really low-grade symptoms. We call them mild. They wouldn't quite rate as a proper symptom. So they include things like very vague persecutory ideation. They say things like, well, every time I go out, it feels like people are watching me. I feel really self-conscious in public. Sometimes when I look at things on the street, like I might look at a tree and I think I see a face in it. I call these like sensory illusions rather than a full hallucination. They might have some odd beliefs, which are not that unusual in the general population. So they might believe that things have special meaning for them, but it's not clear that they're actually a delusional belief. And then we find just under 1/4 of these people have symptoms like frank hallucinations, hearing voices, seeing things that aren't there, implausible beliefs, persecutory ideation. So oftentimes people will actually be concerned about the police, for example, because they are dealing drugs. But the difference here is that when they see the police officer in the tree outside of their balcony and they're having hallucinations that that police officer is taking photographs of them, and that's clearly not plausible, then it kind of would rate in this clinically significant level. And this is where we often see people getting into altercations too because they think other people are giving them a hard time. So they'll go and talk to their neighbour who they think is spying on them and get into a fight with them. And that's where we see that type of behaviour coming in. Most of these symptoms don't last very long, and that's particularly the case where they're directly related to the drug. So you see just about half of them will go away in a couple of hours, a few hours. So this is quite good news. When they're related to the drug, you see them disappear fairly quickly and usually don't cause too much grief. Once the symptoms subside, the person who's using the drug usually has pretty good insight that it was just the drug that was causing the paranoia, and they settle down. However, we do see in some people we get more ongoing symptoms that last longer, and in these cases it's more likely to be either where they're continuing to use the drug, so they don't cut back on the use and they just have repeated paranoia from the drug, or also if they have a vulnerability to psychosis, so it's triggering some underlying vulnerability, and then they get more recurrent symptoms. The symptoms come back maybe even when they're not using the drug. Importantly, we found that only 11% of these people went to hospital. So a lot of these cases are happening out in the community. People will get paranoid, they might get into some trouble, but it's not to the point where they'll get the police call, get the ambulance to take them to hospital. The cases where they do go to hospital tend to be much more severe and much longer lasting, and that's why I think we see a lot of these dramatic cases in the media, because that's really the more severe end of the spectrum that we see at the hospital presentations. We also see a very clear dose-related relationship between the level of methamphetamine use and the probability of these symptoms. And forgive this graph, it's a little bit scientific, it's taken out of one of our papers. What I want you to pay attention to is the black bar here. This is when people were not using methamphetamine. The grey bar here is when they're using up to 15 days in the past month. And the lighter grey here is when they're using more than 16 days in the past month. And if you just look at this bar on the end, you'll see here that when people were not using methamphetamine, only 7% of them reported symptoms of paranoia or hallucinations, so these psychotic symptoms. When they were using up to 15 days in the past month, 27% of them reported those symptoms. And when they were using more than 16 days in the past month, so you're looking here at people who are using pretty much daily, 48% had experienced these symptoms. So a very clear dose-related effect. You see these symptoms more often in people when they're using the drug heavily. And this is the same cohort of people, it's longitudinal data, so we're looking at the same people here as here. And so this is why we say the risk increases when they're using methamphetamine. So what you can see here is when we add in alcohol use firstly, then cannabis use, and then both. And we see a slight exacerbation in symptoms. The prevalence of symptoms goes up to 69%. So if someone's not only using methamphetamine, but they're smoking pot every day and they're getting drunk every day, we see an increase in the prevalence again. We also see an increase in the risk of violent behaviour amongst these people. This graph shows the violent behaviour on the y-axis here, and across here you can see no methamphetamine use, up to 15 days of methamphetamine use, and 16 or more days of methamphetamine use. Now, there's a very clear dose-related relationship with violent behaviour and more methamphetamine use, which is very strong. But in addition to that, what you can see here in the black is people when they haven't had any psychotic symptoms, and you can still see that dose-related relationship here going up. But in the white, this is when they've also had the psychotic symptoms. And you can see it's slightly higher here, and it goes up again. So it's adding to the risk of violent behaviour. And if you're familiar with this scenario, it'll make perfect sense. You take someone and you give them a drug that makes them all hyped up, and they can be quite irritable for various reasons, and then you make them feel paranoid. If you add in that paranoia, it's a bit like adding fuel to the fire. It increases the risk that they will lash out and act often quite irrationally. So finally, what I want to talk about is how we differentiate between methamphetamine-related symptoms of psychosis and schizophrenia. Now, this is a real conundrum in a clinical situation, because the symptoms of methamphetamine psychosis are very similar to the symptoms that you see with acute schizophrenic episodes, particularly with paranoid schizophrenia. In fact, like I discussed before, the chemical mechanism underpinning both is very similar. And for this reason, you see broadly similar symptom patterns that consist of primarily delusions, hallucinations, and then some other psychotic symptoms. And indeed, according to the criteria used to diagnose these two things, it's very hard to tell the difference between them, which leaves clinicians very frustrated. But we've been doing some research and we've been looking more at the more specific symptom profile that you see with methamphetamine-related psychosis and comparing that to what you see with schizophrenia. And we found some quite interesting things. And this is still very early days in the research. We've published a few papers on it so far. So in both cases, you see persecutory delusions. But what we tend to see in schizophrenia, when we look across the lifespan of the person and we ask them about what other delusional experiences they had, they start talking about other types of delusions. So they might have unusual experiences like thoughts have been put into their head, thoughts have been taken out of their head, that the television's talking to them, things that we don't tend to see with methamphetamine psychosis. A little bit more complex, a little bit more interesting, a little bit more bizarre. With the auditory hallucinations, when we talk to people who use methamphetamine and they have the transient type symptoms of methamphetamine-related hallucinations and paranoia, what they talk about is hearing a voice. So they might say, I thought someone else was in the house and I could hear them talking in the next room and I went in there and there was no one there. So quite simple auditory hallucinations. Whereas when people meet the diagnostic criteria for schizophrenia, we're more likely to see complex auditory hallucinations. And they involve things like a voice in the person's head that's making a running commentary on their behavior, two voices talking to one another about the person. So you'll get somebody who presents and they go, well, I've got a couple of voices that I can hear. There's one voice that sounds a bit like my mother and it's a very pleasant voice. And then there's this very angry voice who keeps saying really rude things about me. So much more complex auditory hallucinations involved with schizophrenia. And then we see visual hallucinations, and generally we see hallucinations in both camps. However, we tend to see just a lot more hallucinations with the schizophrenia. We also see a different clinical course. Now, if the symptoms are caused just from methamphetamine use, you expect them to stop soon after the person stops using the drug. And that is typically what we see in experimental inductions of methamphetamine psychosis. What they found, they did studies back in the 1970s, very early 1970s, when this drug was still a medication. And what they found was that they could give people a high dose of the drug that would bring on paranoia and hallucinations and become temporarily delusional. But if they withdrew the drug, usually those symptoms will go away quite rapidly. Definitely within a few days, the person would just sleep for a few days and then they'd feel better. Conversely, if the symptoms persist after someone stops using the drug, then you're much more likely to have schizophrenia. Naturally, in a real life situation, that's difficult to assess because people who are dependent on methamphetamine don't often stop using it to see if the psychosis goes away. They do keep using it, so it's quite a messy picture. However, when we do diagnose methamphetamine psychosis properly, we can see some interesting things about the prognosis. So it is important to try and differentiate between schizophrenia and methamphetamine-related psychosis. So this graph here is a little bit complicated, but this is the proportion of people who had suspiciousness, hallucinations, or unusual thought content in blue, orange, and grey, respectively. These are the common symptoms we see with methamphetamine psychosis. And what we've done is we've used the PRISM, which is a long instrument, which is the only instrument which attempts to differentiate reliably between methamphetamine-induced psychosis and primary psychotic disorders like schizophrenia. And so I've divided this cohort into people who didn't meet criteria in their lifetime ever for methamphetamine-induced psychosis or for any other psychotic disorder like schizophrenia. So relatively healthy in terms of their history of psychotic disorders. And then we've got people who met the criteria for methamphetamine-induced psychosis in the past. And then over here, we've got people who had a primary psychosis like schizophrenia. Then we followed them up for a year. And every month we assessed their symptoms of psychosis and we assessed their drug use. So what I'm showing here is if they didn't have any history of methamphetamine psychosis, in that year when they weren't using the drug, they had not many symptoms of psychosis. And even when they were using the drug, it didn't go up much. So what you can see here is basically this is a very low risk group. They don't experience the psychotic symptoms. However, if they had a history of methamphetamine psychosis, what you can see here is when they're not using methamphetamine, they're actually pretty fine. They haven't had any symptoms of psychosis. But when they were on the drug, that's bang, when the symptoms come out. So for this group here, their symptoms only seem to occur when they use the drug, otherwise they're pretty okay. Then you've got your people with the primary psychotic disorder, like schizophrenia. And you can see when they're not using the drug, they still have symptoms. In addition, what's really important is that when they use the drug, those symptoms get worse. And this is actually quite well documented. So we've got a couple of things to note here. People who don't have a history of methamphetamine psychosis, there are a cohort who don't seem to get these symptoms. But those who, then we've got a cohort who do get the symptoms, but only when they use the drug, methamphetamine-related psychosis, in other words. And then we have a cohort who have symptoms all the time, even when they're not using methamphetamine, but the methamphetamine brings out those symptoms and makes them worse. So this has implications for treatment. For those people with methamphetamine-related psychosis, you need to treat the meth use, because if you treat the meth use, then the symptoms will go away. There's no point treating psychosis because when they stop using methamphetamine, they don't seem to have any symptoms. However, for people with schizophrenia or a primary psychotic disorder, we need to treat both. We need to treat the psychosis because they're going to have those symptoms anyway, but we also need to treat the methamphetamine use because that can make the symptoms worse. So just a closing thought. I hope that I've convinced you from the data I presented today that mental health care should be provided to all substance use patients, at least all methamphetamine using dependent patients, because almost all need it. If you think back to the earlier slides, 88% had either an anxiety or a depressive disorder when they went into treatment. In addition to that, you get a lot of people who have psychotic symptoms. Conversely, drug treatment should really be provided to mental health patients because drug dependence, particularly in the case of methamphetamine, can worsen their symptoms, particularly of psychosis, and that will worsen their outcomes in most cases. So thank you very much. That's all I have to say, and I'm looking forward to getting your questions.
Cool. Thank you so much, Rebecca. That was a fantastic presentation. For our audience today, if today's presentation has raised any concerns for you, we do have a number of support services listed on Cracks in the Ice under the Get Support Now link, or you can always call Lifeline on 13 11 14. So we'll now have some time for questions. There's been a few questions that have come through already, but if you do have a burning question, please do send it through. So firstly, we have a question from a gentleman who would like to know how close are you to having a drug, a DRT for meth available?
A DRT. Can I just clarify what DRT is?
I think he means a drug substitution, perhaps, therapy.
All right. Yeah. So we're a little way off, and it's a tricky business. I mean, we have opioid pharmacotherapies, but that also had a long lead-in period in the development, a lot of investment, both from a research perspective, but also from pharmaceutical companies. And what I think people may not appreciate with opioid substitution therapies is that drugs like methadone and buprenorphine, they're not direct substitutes. They don't just have an action that's the same as heroin. They actually have an interesting interaction with the opioid system that means that they can alleviate some of the withdrawal from those drugs, but also not increase the risk of overdose and other problems. So some of them are actually quite complex pharmacological effects. Now, with methamphetamine, a lot of the focus historically has been on direct agonist drugs. And yeah, sure, if you give someone the same drug that they're taking illicitly, it can reduce the cravings and stop them from taking the illicit drug to some extent. But the difficulty that we've had with those drugs is that they also increase the risk of toxic effects from methamphetamine. And there's risks of diversion. So it's been a difficult road to get those drugs to work. We don't and haven't succeeded in understanding the pharmacology of methamphetamine well enough to develop the equivalent of methadone or buprenorphine for methamphetamine. However, we are doing better, and there are 2 trials going on in Australia at the moment. One is using long-acting agonist therapy, which we think will be an improvement on the straight-up dexamphetamine substitution therapy. That's called the Lima trial. That's going on in Sydney and Newcastle at the moment. And it's using lisdexamphetamine, long-acting drug, which is very similar to amphetamine in its action. But because it's a slow-release, long-acting drug, we think it will work better.
Yeah.
The other trial, which we're leading out of Curtin University, we're doing that in collaboration with a number of other trial sites in Wollongong, Geelong, and Melbourne. And that's trialling a drug called N-acetylcysteine, or NAC, we call it for short. So remember NAC, this is the NICE trial, N-acetylcysteine, or NAC for ice. And this has just started in those 3 trial sites as well. If you're interested in knowing more about that, I'll just put an advert in here. It's www.nicetrial.info. That's a new generation of compounds, and it's aimed at targeting the brain changes that happen with drug craving. It's a very different type of approach. It's generic across all different drug types. But essentially, when someone goes from using a drug to being dependent, there are changes in the regulation of glutamate in the nucleus accumbens, the reward center in the brain, which make it hard for the person to stop using the drug. It makes them crave the drug, and it reinforces that habitual behavior. And we've found that that's an important target in treating addiction, and N-acetylcysteine, or NAC, increases the extracellular levels of cysteine in that part of the brain, and in doing that restores some balance to those brain systems that are disrupted in addiction. So it's a technical explanation for saying it reduces craving, and through that we hope that it will reduce methamphetamine use.
Wow, that sounds really interesting, Rebecca.
We're very excited.
Yes, I'd love to see some results from that when they come out. I have another question from a lady who says, has it been explored whether relapse is something which occurs when people are still depressed, although they are no longer dependent?
Well, it's very interesting that you raise this issue. The craving from methamphetamine, and I suspect a lot of other drugs, can persist for a long time after someone stops using. So officially, when someone stopped using the drug, we would say they're no longer dependent, but the brain changes and this craving for the drug can persist for months. And I've heard in one case up to 18 months later. And if you talk to people who stop using the drug, they'll say it's triggered by maybe environmental things. So they might see an image of, in one case, somebody told me that they would see the ad that was meant to reduce people's desire to use methamphetamine, and because it had some paraphernalia, like a needle on it, that would be enough to trigger a memory of using, being high, and it made them crave methamphetamine.
Oh, wow.
You might be seeing an old friend who they've used the drug with, but in some cases it might also be a mood. So being in a bad mood, or not just being in a bad mood, but being depressed for a lot of people is a trigger that will make them want to go and use the drug. So in essence, yes, the cravings and that propensity to want to use the drug will persist a long time after people are no longer officially dependent on the drug. And it's a bit of a trap, because people stop using and they think that they're doing well, but they don't appreciate the vulnerability that they have, and that they will have that for quite some time after they stop using.
Wow. So I have another question. Just wondering if there has been any research on cognitive impairment from meth use in Australia.
Yes. In fact, I have done some myself. some time ago. A lot of the research on cognitive impairment is also done elsewhere, like in the US. A lot of it's based in the US. But essentially, there is evidence of cognitive impairment amongst people who use methamphetamine. One important thing to remember is that to some extent can be related to the drug, because we know that this drug can be neurotoxic at really high doses. And also when you use this drug heavily, it can reduce dopamine and noradrenaline in the brain. That effect does recover when someone stops using the drug, but it can take some time. And having low levels of those chemicals can impair concentration and memory. In addition to that, however, the lifestyle associated with methamphetamine use means that there are other causes of cognitive impairment in this group: head injury, accidents, polysubstance use, opioid overdose. There's overlap, like some people who use this drug also use opioids. People become hypoxic during the opioid overdose and actually experience cognitive impairment from brain damage from that. Hypothermia, if they take too much of the drug and their body temperature goes up too much. Also, they don't sleep very much or eat a lot if someone's using very heavily. And I'm sure that everyone has had a point in their life where they've experienced what it's like to be jet lagged, for example, or just not having eaten for a long time. And you know your brain does not function very well in those circumstances. So there are multiple reasons why you see cognitive impairment in this population.
Okay, good to know. So I have another question. When someone is experienced mild meth-related psychosis, is there a effective response that you could recommend to help them?
I think in that case, harm reduction, educating people about the symptoms that they might experience. So people, when they're in the early stages and they're having these mild types of symptoms of psychosis, we'll talk about seeing the shadow people. They see things in the corner of their eyes and then they turn around and they realize there's nothing there. They might hear someone calling their name and turn around and find there's no one there. When they experience these mild symptoms, if you can educate them that these are mild symptoms of psychosis, that they are related to the drug and that they need to take a break, reduce their use and have a sleep, that's probably the best thing that we have at the moment.
Okay, yep, good to know. Does the effect of methamphetamine on serotonin last for a very long time, or does it cease with reduction or cessation in meth use?
It's not known at the moment what the long-term effects on serotonin function are. The changes in serotonin function have been seen in people who've used the drug chronically, but no one's really looked at the recovery of that. They have looked at the recovery of dopamine function in the brain, and there does appear to be some recovery in function that you see maybe 12 months later, but it's still ambiguous whether that's a complete recovery or not.
Oh, okay. Apologies, I'm just getting over a mild cold and it appears it has attacked me just at the end of our webinar. So I've just got a couple more questions. One is, did your studies only look at adults, or was there any research associated with children and adolescents?
We only looked at adults. We couldn't get ethics to look at children. I suspect this person might be asking because they know that dexamphetamine and Ritalin and drugs like that are related to amphetamines and they're used in children. But just please be assured that at those low doses taken orally, you don't see the toxic effects. It's not to say that there's not an increased risk of experiencing some of the psychotic symptoms or some of the toxicity, but it's much lower.
Okay, that's good to know. So the second to last question is, someone would like you to discuss the evidence-based psychological therapy intervention to support recovery for consumers. So I think they've obviously heard me mention breaking the ice and would like to hear more about it.
Okay, all right. I guess I should start by saying the best evidence we have currently for treating people who are dependent on methamphetamine is cognitive and behavioral therapies. And I know that they're not always the most popular treatments to be administered by clinicians, but effectively, cognitive behavioral therapy is our gold standard for treating people who are dependent on this drug, and contingency management, which is not used here in Australia, but that involves reinforcing abstinence or reduced use from the drug. It's usually done in terms of monetary reward, and that's a method that's very effective, but it's more used in the USA. Now, Steph was referring to the web-based interventions. So what we've tried to do is translate some of these treatments into an online format. And at the moment, the web-based intervention that we've got, it's targeting people who are using the methamphetamine, but they may be experiencing symptoms of dependence, but they're not the kind of people that are ready to go to rehab. They're not that severely dependent. And what we're trying to do is use motivational techniques to get them to reflect on their substance use and motivate them to reduce their use, to reconsider how their use might be impacting on their health, and to seek help if they are at problematic levels of use. And that's called breaking the ice. If you Google breaking the ice as one word, you should find that intervention. I believe it's on the Cracks in the Ice website.
Yes, it is. Yeah.
Yes, brilliant.
So someone was interested to find out what survey was utilised to evaluate the symptoms of drug-induced psychosis of meth versus a schizophrenia.
Okay, it's called the PRISM, and I'm just trying to remember what PRISM stands for. Psychiatric actually, I might, have you got the person's email? Can we email them the instrument later?
Yes, of course, yeah.
Yeah, but PRISM, P-R-I-S-M.
Okay, not a problem. All right, so I might just have a look and see if there's any more questions. There is one. What about using Ritalin in place of methamphetamine, like methadone for opiates?
Yes. Well, like I discussed earlier, there have been a number of trials that have looked at using Ritalin and dexamphetamine in place of methamphetamine, and they've had mixed results. They haven't really produced positive effects. They haven't significantly reduced people's illicit use of the drug. One of the reasons is the dose is very low compared to what you would take if you're taking illicit methamphetamine, but also it's just, you get a lot of toxic effects with the Ritalin if you take it in doses that are high enough to stop people taking the illicit form of the drug.
Yeah.
So we've seen high rates of toxicity, and with drugs like methadone and buprenorphine, you don't have the direct toxic effects. You have risk of overdose. And the pharmacology of methadone and buprenorphine is actually a bit more complex. It's not exactly the same as heroin. And this is important to understand. It's not like giving heroin for heroin. There are pharmacological properties of those drugs that do reduce the risk of toxicity and overdose. And we haven't got to the point with methamphetamine that we understand the pharmacology well enough to come up with an equivalent for methamphetamine.
Cool, great. Well, thank you for being so patient with all these questions, Rebecca. I just have one more, which is, can you describe the differences between the anxiety induced by using methamphetamine versus an anxiety disorder?
Okay, so I don't think there was a lot of difference in our case. It's people report the same types of symptoms in both cases, and I think what happens is when people use methamphetamine, it exacerbates their anxiety. So you think about the effects of methamphetamine, it increases heart rate, it increases sympathetic arousal, so you get that sweaty palm, like shaky kind of feeling that it's actually not dissimilar to feeling very anxious. And so when people do have a propensity to become anxious, like if they are experiencing or prone to panic attacks, then they take the drug, their heartbeat goes really fast, they start getting the sympathetic arousal. It can actually trigger, it's like a cycle, it can trigger those underlying panic attacks. So I think what methamphetamine does is it exacerbates those symptoms. As for the data that I presented, that's quite crude. We just asked people about the symptoms. So the symptoms are exactly the same. But then we say, do you only get this when you're using methamphetamine, or do you get it at other times? And if they only get it when they use the drug, and consider that these people are dependent on the drug, so they're on the drug most of the time, then they say, yes, it's substance related. So it's really just their own personal attribution. And I actually don't think that that is terribly reliable. I think it's just because people are using the drug all the time, they assume that if they stop using it, it will go away. That's not always the case.
Okay. Well, thank you so much for today, Rebecca. It was a really fascinating talk, and I think you can tell how engaged everyone was by the number of questions we received.
Yeah, thank you very much for listening, everyone.
Yes. So firstly, thank you, Rebecca, for giving us your valuable time today and sharing some insights with us. And also thank you to everyone who joined us for the webinar. Apologies to anyone who didn't get their question answered today. You are more than welcome to get in touch with us via email and we will respond to you as soon as possible. We will be holding more webinars throughout the year, and as well as putting new resources on the Cracks in the Ice website. So I'd encourage you to join our mailing list at www.cracksintheice.org.au. So thank you all again, and I hope you have a lovely day. Bye.
Thank you. Bye-bye.